Hi everyone, my name is Daniel Morales. I'm an academic GP and epidemiologist from the University of Dundee. And I'm going to speak to you about renin-angiotensin system blockers and susceptibility to COVID-19. So early in the pandemic, hypertension and heart disease were recognized as common comorbidities amongst people with severe COVID-19. And this led to speculation it was the treatments for these conditions that patients were on that may have influenced the severity of the illness. The rationale behind this is that ACE inhibitors and angiotensin II receptor blockers are common treatments for hypertension and heart disease, and these drugs may influence an important receptor that's required by the SARS-CoV-2 enzyme to enter the human cells, namely ACE2. This generated lots of public health concern and led to messages released from medicines regulators and clinical societies recommending that in the absence of evidence of harm, that these drugs should be continued as normal during the COVID-19 pandemic. And the purpose of this study was try to fill some of those evidence gaps. So there's two potential hypotheses here. The first is whether ACE or ARB use is associated with an increased susceptibility to COVID-19, i.e. I'm more likely to contract the illness. And secondly, once you have contracted the illness, whether being on an ACE or an ARB influences the severity of that illness. Our study looked at both of these questions, but the purpose of this presentation will focus on the first hypothesis on susceptibility. So this was a federated analysis using 3 databases. We used the CityApp database, which is a GP electronic health record database linked to hospital admissions, covering about 6 million patients from Spain. We use the Department of Veterans Affairs database. This is a linked administrative claims database covering around 12 million patients from the US. And also the Columbia University Irving Medical Center Data Warehouse. This is an electronic health record covering around 6 million patients from New York City. This slide shows our study design, our eligibility criteria, and our outcomes. Our target comparison were ACE and ARB users, which we divided into those on monotherapy and those on combination therapy. And our comparator cohort were patients prescribed calcium channel blockers and thiazide diuretics. So this was an active comparator cohort study. Our main study outcomes that we focused on was COVID-19 diagnosis, COVID-19 hospitalization. We also included 2 other outcomes, that of hospitalization with pneumonia and a composite outcome of hospitalization, pneumonia, ARDS, acute kidney injury and sepsis. For the rest of the presentation, we'll focus on the risk of COVID-19 diagnosis and of hospitalization. We used 2 propensity score adjustment approaches. We used propensity score stratification into quintiles and propensity score matching. We then applied cost regression analysis to generate hazard ratios and also undertook negative control experiments, the results of which we also used to calibrate those hazard ratios as a marker of capturing any unmeasured residual confounding. This slide here shows an idea of the numbers amongst the different comparisons and drug exposures amongst the groups for CityApp and the VA. As an example, we included overall a total of just over 360,000 ACE-ARB monotherapy users and compared that with around 250,000 monotherapy users of calcium channel blockers and thiazide diuretics. And amongst that comparison, the incidence of COVID-19 diagnosis, as an example, was 5.6 versus 4.8 per 1,000 person years, respectively. This slide shows the propensity score balance after construction, with that of stratification on the left and a propensity score matching on the right. For both CityApp and VA, following propensity score construction, standardized mean differences were all less than 0.1 for all of the drug comparisons. However, for data from Columbia, all but one drug comparison had residual standardized mean differences in some characteristics of greater than 0.1. However, these were resolved through propensity score matching. And some of the key differences between ACE and ARB users and the calcium channel thiazide diuretic users were in sex, diabetes, chronic kidney disease, heart disease, and heart failure, for example. This slide here shows calibrated hazard ratios for a comparison between ACE/ARB users versus calcium channel and thiazide diuretic users for both the monotherapy and the combination analysis. The results for the propensity score stratification are seen by the black solid circle, and that for propensity score matching by the white circle, with the estimates in grey showing the estimates that actually failed propensity score diagnostics. The outcomes here for COVID-19 diagnosis and hospitalization, and as you can see amongst all of the pooled analyses, there was no difference in the risk of COVID-19 diagnosis or hospitalization with ACE/ARB use versus calcium channel or thiazide diuretic use. We also did a direct comparison between ACE inhibitors and angiotensin II receptor blocker users. We saw a very small protective effect amongst ACE users compared to ARB users for COVID-19 diagnosis, with a hazard ratio of 0.88, confidence interval 0.79 to 0.99, mainly in the combination analysis, but we didn't see a consistent pattern or results when we looked at COVID-19 hospitalization as an outcome. So the study has some potential limitations. First of all, we used a prevalent user design, whilst currently a gold standard would be considered a new user design, which just was not feasible due to the nature of the COVID-19 pandemic. Now, one of the key factors about a prevalent user design is you may adjust for mediators on the causal pathway between an exposure and an outcome. But COVID-19 is unlikely to have influenced this significantly, as most people have been started on this prior to the pandemic emerging. Therefore, one of the key concerns around depletion of susceptibles is therefore not likely to be a strong influencer here. And finally, the biological mechanisms about the risk concerning ACE and ARB users is more likely to affect those on prevalent or chronic use compared to incident use. And lastly, our outcomes, or COVID-19 outcomes, are defined using diagnostic codes and positive tests. And these are going to be an underestimate of true community transmission. And the quality and type of capture of these outcomes may vary by the data partner and the type of testing strategies. However, this difference is likely to be non-differential between the actual drug comparisons within each database that we're looking at. So in conclusion, these findings support the regulatory and clinical society guidance to not modify or change your ACE or ARB treatment, given these concerns. But equally, the small differences seen between ACE and ARB users really don't suggest or warrant switching to try and reduce COVID-19 susceptibility. This slide here posts all the links to provide further information and for running the packages. I'd like to thank the large group of people who were involved in the study, design and conduct, and also the funders, and including the leadership from Professor Mark Suchard to drive this forward. Well, thank you very much for listening. Look forward to working with you all later, and if you have any questions, please just contact me.